Warm greetings, friends. And, my talk is quite a complicated one because I don't have any answer, and none of us, I think, we really have answers for this major problem which is facing our current generation. And attracting talent to pediatric cardiac surgery somehow, I think, is an illusion for me so far. It's becoming gradually more and more difficult, and possibly this is the uh, uh, one of the major points which should be discussed for the next 5 years or 10 years, consistently, relentlessly among the public platforms, and maybe then I think we'll make some difference. But it's important to bring it into public domain that the talent is refusing to come, or at least hesitant or reluctant to come to pediatric cardiac surgery. And that's the reason I put this slide, elephant in the room. And this sort of symbolizes that the importance we should attach to this particular topic. So having said that, my first point, what I want to say is that the prevailing scenario, all of us, we are aware, there are few takers to this specialty anymore. The workload is immense, work stress is immense, and care delivery is disparate within the country, within the regions of the country. There are private, there are public, there are philanthropic, there are charitable institutions or platforms which are delivering the care in a sort of free-spirited manner without any standardization across the platforms. So having said that, let me do a SWOT analysis of the this problem. What are the strengths of this specialty? The strengths are 80% of the congenital heart defects are still in the hands of a surgeon, and the society is in general kind to jobs that are related to children. Having said that, the weaknesses are plenty. The biggest of the problem we have is no one has money for congenital heart surgeries, including government. And this is across the board. Maybe 4 out of 5 children, what I see in my OPD for the last few years, do not have access to care because of the financial challenges. And it is as if it is a social responsibility has been thrust upon that on all of us, pediatric cardiologists and surgeons, that we need to take care of this, and as if it's not the society's responsibility. And as far as I am concerned, it is the other way around. We are supposed to take the professional care of these children, and the society should be actually patronizing this profession rather than going the other way around. And the biggest problem is that once the surgeon qualifies and he comes out, he is left to fend for himself in most of the programs, barring few privileged centers. And just to give a sort of, it's a small digression, what I want to make is that this is in the context of recent Nobel Prize for Economics by Card and his associates, and where they have gone to identify economics vis-a-vis poverty at the social level. And one question which has been posed is that would one extra year of education increase earnings, and by what magnitude? It's a very interesting thought when you contextualize this particular problem to pediatric cardiac surgery. And I feel that, this 1 year extra, 2 years of extra beyond our postdoctoral course when we do in pediatric cardiac surgery, it's the prevailing scenario is as if, it's a punishable act for us, that the work stress is increased, the remunerations drops down, and your family time and personal time have been thrown out of the window. The second example, what I want to give is that, this is very glaring for me, and that's the reason I put it in the center of the slide with a blue background. And this is the government programs which are actually helping the public who do not have access to healthcare in tertiary specialties, wherein the BT shunt has been clubbed with a bronchoscopic foreign body removal, like as if the child has got a one small peanut or something like that, when it gets stuck in the bronchus. The amount what is paid for bronchoscopic removal of that foreign body and the BT shunt have been clubbed together as if they both are of the same intensity and same complexity. This I find quite disheartening, and but our problem, or the problem which is pertaining to CVTS in general, is not really limited to India alone. It's a global phenomenon. This is a recent article which is going to come in the next few months from Canada, which says that the hourly earnings Actually, when they calculated the differences among specialists, it was most pronounced in cardiothoracic surgery with a huge difference in fee for service system. And that is, again, it gives a glaring view of what's happening in the private sector in India also. So, having said that, they have come out with some of the recommendations which say that somehow we need to help the work and life balance for these professionals, and we need to create a supportive culture, and we should have a zero tolerance of harassment. I don't know, this was the statement was made because this article is pertaining to women in cardiothoracic surgery, but I take it in the different context in pediatric cardiac surgery because it's a harassment from the society and from our fellow professionals, or otherwise from the organizations in general when we go,
It
where
says
we
you
work.
cannot share.
And that I think needs to change. Again, the weaknesses. Training is in decision making and surgical skills and post-operative hemodynamic care. That's what we have been trying to do. But when the reality hits him or her, once they graduate and come out, it is basically, other than operating, all other responsibility have been thrust upon them. And remunerations are remaining dismal vis-a-vis other specialists. And cardiologists are becoming busier with increasing interventions and has less time for perioperative care, which is perfectly understandable given the explosion in the interventional cardiology, even in congenital heart diseases also. Overall, bottom line for pediatric cardiac surgeons, it essentially drops down, boils down to one aspect: more work, more stress, less personal time, modest income, lack of appreciation or recognition. So, what are the opportunities? Do we have opportunities for pediatric surgeons? Yes. I mean, if somebody wants to work Monday to Sunday and Sunday to Monday again for next 10 years, we have got a humongous amount of workload which is there for congenital heart surgeries, as long as somebody funds it. And the fact is that that is not there, is the one which puts a big blipper onto this. And there is a adult cardiac surgery field which is completely saturated, and there is a higher chance that out of helplessness the adult cardiac colleagues might come down, might overlap into pediatric cardiac surgery these days. Having said that, very few people are taking the cardiothoracic surgery degree as such. So I am not sure that to what extent this is an opportunity for us, because despite having very less number of pediatric cardiac surgeons, the fact remains that people are not willing to come to our specialty. And what are the threats? Threats, I think it's quite fairly straightforward. Ever increasing and enveloping interventions, all the simple congenital heart defects, whatever Dr. Iyer was telling, we should be 70% of the workload have gone into the hands of the pediatric cardiologist. And there is a lack of interest in pediatric cardiac intensive care. There are less positions in private. There are hardly any positions in public sector. Specialty is being treated as a completely non-rewarding field by the current generation, which is aspirational in its own way, and it reflects the society. And then there are uncertain positions in philanthropic institutes because we do not know how far they will last. So is there a way? It's a very difficult question, as I said in the beginning. But one thing I am fairly certain, that after spending 3 decades in pediatric cardiac surgery, let me tell you that let's not be apologetic for being what we are, because whatever we have accomplished professionally has come at a great cost, and we are quite proud of what we have accomplished in the last 30 years for this country. There is a wholehearted participation of government and people of the country which is needed to encourage people to come into this specialty, and that needs to be lobbied harder in the public domains, in the press, maybe in the media, maybe with the famous or very well-known public personalities who can actually bring pressure to the system to change this perception towards our specialty. And maybe perhaps integrating public and private platforms, I think, is a very good idea, so that the mentees feel that there is opportunity for them to operate, and then the mentors feel that there is room for them to actually train the next generation cardiac surgeons. And most importantly, as far as I'm concerned, we should rationalize the training of proportionate to the requirements of this country. And we should not be under the illusion that just because we graduated or we trained somebody, that he is going to be happy with the new position what he's going to occupy in the society, because vacancies are is in the air. It's not there on the ground, because no paid positions really exist in India right now for pediatric cardiac surgeons, and it's not in any sector, private or public. And then we should encourage the associate specialties, and their training should be transformed in such a way that they share the burden of the ICU care. And we need to accept the pediatric heart care is expensive and someone should pay for it, rather than thinking that we will readopt. We will reach a situation where otherwise we will be readopting, we'll end up breaking our back. We shouldn't do that. And there is a need for decreasing the workload for the surgeon outside the theater and appropriately compensate for it. I'm just putting these masterpieces to say that we admire them, we adore these artists who created, whether it is Raja Ravi Verma or otherwise Michelangelo or Da Vinci. They are masterpieces. But the fact remains that I'm telling with pun intended that these paintings were on inanimate objects. But this brilliance was patronized either by the kings, states, and society, or the artists themselves were fairly well off. And this artwork were executed by men who were fusing both art and science to make these lasting impressions. They were actively encouraged, and conditions were conducive for them to do it during those times. We are no less. Our artwork is on a live human, and life is at stake if the artistry goes bad. So we are as good as any artist. We should be proud of what we have accomplished. Probably this is the biggest attraction to become a pediatric cardiac surgeon. And to summarize, I feel that we should not attract talent deliberately, because we do not have the right to do that. We should retain the existing ones. And the guys who are obsessed or passionate with this specialty will, regardless of the challenges, they will continue to take up this field. And do not start any new training program, for heaven's sake, unless you assure them suitable placements. It would be a disservice otherwise, and we will be damned as one more exploiters in the current times. In short, it has to be equitable, it has to be diverse, it has to be inclusive environment for the pediatric cardiac surgeon to sustain. Thank you.
Thank you, sir.